Distinguished guest, Mr. Thomas Berenberg from Mayo Clinic. Distinguished guest, Mrs. Julia Berenberg from Mayo Clinic. Distinguished guest, the delegations from FK Hospital Jakarta. Distinguished head of the cardiology and nursing departments of Faculty of Medicine, Universitas Gadjah Mada, eminent professors, lecturers, students, and participants of the open lecture. A very warm welcome to you all. And this morning we gather here to have an open lecture or a continuing medical education from our distinguished guest lecturers from Mayo Clinic, USA. And before we begin, let me read the highlights of today's event. This event will be opened by the head of the cardiology department, Dr. Haryadi Haryawan, and then will be followed by an introduction from Dr. Haryadi Haryawan, and then we will have the main event from the guest lecturers from Mayo Clinic USA, Mr. Thomas and Julia Berenberg. And with no further ado, now I would like to invite Dr. Haryadi Haryawan to give the introduction. You may have the floor, please.
Baik, selamat pagi. Assalamualaikum warahmatullahi wabarakatuh. Ya. Pada kesempatan pagi ini kita akan kedatangan tamu ya dari Mayo Clinic. So, dear Vice Dean of the Gadjah Mada University Faculty of Medicine and all of the participants. Well, first of all, let us praise to all Almighty, because of His blessing, we are able to stay here attending this meeting. It's the one of the continuing medical education in Faculty of Medicine, Gadjah Mada University. I would like to say many thanks to the Dean or Vice Dean who have given us an opportunity, Department of Cardiology, get some of scientific session on CME, especially for Dr. Thomas Berenberg and Mrs. Julia Berenberg from Mayo Clinic, USA. They will give us the lecture on behalf of all of the staff of the Department of Cardiology. We say selamat datang di Yogyakarta. Enjoy traveling here. Please visit Yogyakarta. Maybe you will visit the Prambanan temples, Borobudur, Keraton Palace, and maybe Merapi, you know, in the north of the Jakarta. Yeah. Ladies and gentlemen, we have two guest lecturers from Mayo Clinic, Minnesota, USA. The first, Dr. Thomas, MD, PhD, consultant of cardiovascular disease, and associate professor of medical college of medical Mayo Clinic, and his wife, Mrs. Julia, Master of Science, Master of Public Health, Patient Educational Specialist, Department of Nursing, Mayo Clinic. We are coming to Indonesia for attending speakers in FK Hospital Jakarta at Symposium. It is Midwest in Cardiology update. You know, the medical profession should play a central role in evaluating the evidence related to drugs, devices, and procedures for the detection, management, and prevention of the disease. In our hospital, the teaching hospital, Sarjito, We have some modalities for diagnosis and treatment for cardiovascular disease, like treadmill test, echocardiography. There is transthoracal echocardiography and transesophageal echocardiography, vascular Doppler echo, Holter monitoring. We have 2 unit catheterization laboratory with FFR, fractional flow ratio, Bischoff, electrophysiology study laboratory for ablation. We have MSCT, multiple CT scan angio, or cardiac CT. And we have cardiovascular surgery team for operation like cabbage, congenital disease, vascular disease. But we don't have some like nuclear imaging, like gamma camera, SPECT, single photon emission, and we don't have MRI, magnetic resonance imaging, IFUS and OCT, we don't have. The inpatient in ICU, intermediate care and ward of cardiology is almost fully every day. The bed occupation ratio almost near 100%. The patient of polyclinic ambulatory about 150 patients per day. And not all of the patients funding by insurance. So this can improve the quality of diagnosis, treatment, and favorable effect caused by focusing resources on the most effective strategies and procedure. So we have to choose which the modalities we can perform to make diagnosis and treatment. And now, important modalities are education, communication for patient and their family. How patient and family education in hospital can improve health outcome. So, Mrs. Julia Pekenbeck will give us the important lecture this morning, and we hope will share for us how about education at Mayo Clinic. It will be useful for my institution. That's for Mr. and Mrs. Pekenbeck, our special speakers. Thank you for your special visit here. Share for us, and maybe sometime can visit Jogja again. Hopefully, it will be useful for all of us and for all of the participants. Thank you very much for your attention. And the meeting is open right now. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Good morning. Thank you very much for having us, my wife and I, as representatives of the Mayo Clinic here in this lovely place. When we were asked to give a presentation, the dean and the head of the medical department had asked whether that I should talk about something that I do at Mayo Clinic and that represents something that I like to do. And my background, I'm originally from Germany. so I speak German fluently, and I went to America to study, and before I knew it, I ended up at the Mayo Clinic. Say in America, a picture is more than 1,000 words. So I was naturally drawn into imaging. So I thought, instead of giving you just a dry lecture about some topics, I'd share with you what I actually really do at the Mayo Clinic, and I'll share some of the cases that we see at Mayo Clinic to make you understand why it is so much fun to work there. So, in America, we always have to disclose if there are any specific interests of commercial value. I don't have any. And I just wanted to show you, before we go into what I do, how Mayo looks like, how Rochester looks like. This is a view from the river that runs through the city, and all this that you see here is part of our medical city. For those of you who have traveled to America, Rochester is very small. We have only 100,000 people living in Rochester. Mayo Clinic employs 50,000 people every day who work at Mayo Clinic in Rochester alone. What you see here is actually an overview of the campus. These two are the buildings where our clinic is in. This is an administrative support in the Plummer building. This happens to be a hotel. This is one of our hospitals that's affiliated with us. Here is a senior citizen home that we run. If you drive down this road about half a mile, here is one of the largest private hospitals in the world, St. Mary's Hospital, which belongs to our campus. This is a view of our newest building, the Gonda building with its main entrance. This is when you have walked inside. This is one of the staircases of the three that gets you from the ground floor, which would be here, to the ground level. This is actually underground, even though we have a large atrium here. And the reason it is underground is shown in the next slide. This is how Mayo literally looks like today. This is, remember, this is the same sign I showed in the previous slide. This is currently the weather we have at Mayo in Rochester, Minnesota. We have winter for 5 months of the year. And currently, as I'm speaking to you, we have a snowstorm raging through Rochester. These are not the last two patients who didn't get an appointment for the day. These are, next slide please. This is the sculpture of Charles and Will Mayo, now during the summer without the snow. They are the founders, really, of Mayo Clinic. Actually, it started with their father, but they came up with the name Mayo Clinic from, they adopted this name officially. Let's take a next. This is a typical day at Mayo Clinic. We have about 5,500 patients, outpatients visit in the polyclinic every day. We admit about 250 people every day into our hospitals. On average, we have about 130 to 140 patients in our critical care units every day, and we're doing between 200 and 210 surgeries every day in our 110 operating rooms. Half of our patients are well within traveling distance of about 180 kilometers. But the rest of our patients come from all of America, and I think we have seen patients from every country in the world so far today. Next. We are a very large institution. We have just in Minnesota, aside from who works at Mayo Clinic, we are responsible for an additional 35,000 supporting jobs in Minnesota alone to support the Mayo Clinic. We directly employ 75,000 people in Minnesota, but we also have satellite clinics and hospitals in Arizona and in Florida. Today, we have more than 3,700 full-time physicians and scientists. There are about 2,700 physicians, and there's about 1,000 researchers at our institution. We have 5 fully accredited schools to train the employees we need. We have our own medical school in Rochester. We started our own medical school in Arizona, and we have other schools that help us educate people that we need to be a cutting-edge institution. We also work in the communities. We own 63 community hospitals and clinics that surround us in Minnesota and Wisconsin and Iowa alone, and another, I think, 50 distributed pretty evenly between Florida and Arizona. Next slide. Currently, we have about 2,500 students in our program. We have 140 medical students who will become doctors in Rochester. We will begin a class this year of another 40 medical students in Arizona. But you can see that aside from that, we have a very large program for any medical position that you can think of. Radiology technicians, echocardiography students, anybody that works in the healthcare field, we are trying to train to our own standards. In addition, we have a very large specialty and subspecialty training program. We have currently 1,500 residents and fellows, that's what we happen to call them, who want to specialize from a general practitioner to cardiologist, surgeon, cardiovascular surgeon. We train every specialty that exists in medicine. Oncologist, you name it. Last year was one of our most important years because we were able to touch about 600,000 people with our educational programs who enrolled into our CME programs around the world. That's, next slide please. We are equally busy in our research aspect. Currently at Mayo Clinic, as we speak, there are 2,500 independent patient and research-related studies going on. There are over 8,000 active studies that are going on, and every year we are generating 2,500 new studies. Every year we publish more than 5,000 articles in review journals. These are not the one counting the ones that we are invited. So these are all competitive journals. And we're spending, we have $360 million every year in external funding, but because of our performance, we double this money. We are having about a budget of $800 million for research every year. Mayo is very unique. We are private, but we are non-for-profit. That means we make a lot of money, but by law, every dollar has to go back into the Mayo Clinic to improve the Mayo Clinic. We cannot pay profits. We cannot, make all of us wealthy by increasing salaries. They are fixed. We are all salaried. All this profit goes back into the institution to make us better. So that gives you just a little bit a glimpse of the size of who we are. And often the question that I get is, if it's that cold, how can you be so big? And honestly, I cannot give you the answer, because I still think it's too cold, and that's why I'm so glad I'm here. Now, now let me switch gears a little bit, and I'm very happy to answer any questions afterwards. But let me switch now to the purpose of the talk. What I do is I do all the imaging procedures. So I do MRI, CT, nuclear, echocardiography, intravascular echocardiography, intracardiac echocardiography, OCT, you name it. This is what I do. I also am what is called an interventional imager. I do not do balloon angioplasty or stenting, but I do all the other interventional things like pericardiocentesis, percutaneous valves, and things like that. And so I actually lead a wonderfully exciting life, and I want to share this with you. And the purpose that I really want to point out is you want to use all your tools in life to get the best result. You should never be afraid to ask colleagues for help. You should never, ever think that alone you are the best, because believe me, you are not. Together, you're always better. So let's get started. The first case that I'm going to tell you is stop while you're ahead. Click again. And think. This is a gentleman who was 66 years old, and he presented to an outside hospital with shortness of breath, and he had blacked out. The diagnosis was made very quickly. He had a blockage of the aortic valve, but he was overall a very, very ill person. He was obese, he had coronary artery disease, he had obstructive sleep apnea, he had fatty liver disease, he was just diagnosed with early stages of liver cancer, and he had a low thrombocyte count. He was considered at the outside hospital for the partner trial, which is to place an aortic valve percutaneously. Our colleagues at the outside hospital felt that that was, when they started, they ran into trouble, and so they converted this. First of all, they did a bare metal stent, and then they did a 25 millimeter St. Jude bioprosthesis in December of that year. They monitored the patient carefully in the critical care. And everything initially went well. They had noticed that there was some wound healing problems, but they felt that that was due to diabetes. But the family was kind of nervous about this, and they said, would you mind transferring him to Mayo Clinic? And so that's where I met him. He came to us 2 weeks after the surgery, and this is why medicine is so much fun. He came, and my resident saw him, and then I got a phone call, and the resident said, you better run over here. He isn't doing very well. And I said, that can't be true, because my colleague from the outside hospital said, it's a little bit of wound healing problem. He said, no. He isn't doing very well. So our colleague in the critical care unit then ordered an echocardiogram and said, this is your field, just go at it. Next slide. And this is the echocardiogram. And for those of you who are not familiar with it, there is the left ventricle, the left forechamber, the mitral valve, the right ventricle, the right forechamber, and this shouldn't be there. That's a large amount of fluid around the heart, which we call pericardial effusion. And that's why the patient wasn't doing so well. So we drained this out. It was a large pericardial effusion. He had the classical signs of shortness of breath, low blood pressure, and I was able to get 1,700 cc's of bloody fluid out of him. And the patient did well. He said, oh, I'm feeling so much better. But then he told me, I'm no longer short of breath, but now I have chest pain. And I thought, great. I got from the fire into the frying pan. What I also noted is that the fluid was coming back quite rapidly. And it worried me, and so I called the colleague who took care of him and said, this is not looking good. And something interesting happened. About 5 minutes later, the patient said, oh, doc, I don't know what you did, but I don't have any more chest pain. But I'm getting a little short of breath again. So we were starting this all over again. Next. And then I said, this we have to figure out, so we will get a CT. So, I'm sorry, I don't know why it doesn't repeat. It should have played over again, but that's okay. Let's go to the next one. Yeah, let's leave this running. Now there's a catheter in there, and now it plays again. And for those of you who are familiar with it, they should see something that should worry you. It's coming right up here. Right there. Let's go to the next slide, then it's becoming more evident. Here it is. What happened in the outside hospital, the wound healing that they had reported was indeed a huge problem. Because what happened is that unbeknownst to them, the metal clasp that we put around the sternum to stabilize it had actually broken. And the pin had pushed into the heart. So what happened is, when we started draining the fluid, the pin reached the heart and literally poked into the ventricle, and the patient had chest pain. When the fluid reaccumulated, the chest pain went away, but the shortness of breath came back. So next. And this is where things get interesting, because we decided at that point there was no way we're going to stabilize it. The clasp had to come out, so we took the patient to surgery, and we never, ever, ever perform cardiac surgery without an intraoperative transesophageal echocardiogram. And now you see the next problem. And the next problem, this is the left atrium, this is the aortic valve, this is the ventricle, this is the mitral valve, the anterior leaflet, the posterior leaflet, and do you see this little thing that's coming up here? That little wavy thing right there? That's called a vegetation. So unfortunately, with the wound healing being a diabetic, he also had developed endocarditis. So we rewired. Unfortunately, things got really, really bad because we could not improve the wound healing. It turned out that the patient actually had an underlying malignancy, and after we had considered actually chemotherapy, the family decided at that point, and the patient, that they just did not want to continue, and this patient unfortunately expired after they realized that in the end the patient would have to undergo mitral valve replacement. So let's go to the next case. This one, actually fairly similar. 50-year-old gentleman came to us, severe aortic stenosis, had a valve replacement. We see these patients all the time. Very many other underlying diseases. That's kind of our bread and butter. That's what we do. Next. He had no significant coronary artery disease, and we implanted a 23 millimeter St. Jude, and he was discharged 5 days later home, and he was very, very happy. But he came back 3 days later to my service, to my cardiology service in atrial fibrillation, and he had a very fast heart rate. Here it is. Everybody can see this is an irregular, very fast heart rate, 144 beats per minute, atrial fibrillation. Next. We were very able to quickly rate control him, but he continued to tell me he was short of breath, and then he became hypotensive, low blood pressure. This is the chest X-ray at the day of discharge. This is the chest X-ray the day he came back to my service. And you can see that the cardiac silhouette all of a sudden is very, very large. And without further ado, we got an echocardiogram. Next slide. And you can see the same thing here. Very small, very hyperactive left ventricle, large amount of fluid. And so I told my fellow, go ahead and drain that out. So we did. And he said, very successful, not a problem, large circumferential pericardial effusion. But he said, you know, I got a little bit into problems, so I got him into the CCU because, you know, while I was trying to do it in the room, we all of a sudden had low blood pressure, and indeed, he said I was able to withdraw 1,350 cc's of fluid. Next one. Patient was wonderful. He said, you guys cured me. Without doing anything on our part, he converted to sinus rhythm. Next. And so all wells that ends well, right? Well, not quite. He came back 8 days and said, Doc, I got the same problems. Same large heart. And I thought, this is very strange. So same holds. The physical examination showed that there was a swinging heart, and we had the same problem. Next slide. So this time I said, let me do this because just maybe we're missing something. And so I did it. And we did 1,200 cc's of fluid, and next, click on it. This is what I got out of this patient. And I'm going, since when do I get susu out of a patient? There's milk. And I'm going, can't be. So I left the pigtail catheter in to say, what's going on? And I showed this to my colleague, and he said, that's lymph. That's not blood, that's nothing, that's lymph. He said, give it to the lab, and indeed it was. Next slide. So, because we have all the imaging, I said, this is easy. We're going to do a lymphoscintigram. We're going to show that there is lymph drainage. Well, the test was negative. Even after 24 hours, nothing. Next slide. However, you cannot deny what you got. So we actually asked the surgeon to go back in and take a look. And it was hard because the surgeon looked at me and said, you got to be kidding me. I'm going to open a guy up that I just closed 4 weeks ago just because you think you got lymph drainage out of there? I said, I have what I have. And this is what the heart looked like. This is a view of the heart when the patient was opened up. It was so the patient was discharged. He's happy. He's now 2 years out. Never, ever dismiss something just because you think it cannot be. That's when you get caught. Last case, and then I'll be done. Can you go back, please? You have trigger finger. Never be surprised about anything, or you will miss the important thing. And this case is actually dear to my heart. It's a lovely patient. Let's click. Next slide. It's a young gentleman, 32 years old. He came to the emergency room, and a colleague called me there, and he had persistent cough. You know, in Minnesota in the winter, everybody coughs. For 3 weeks, but then he said that he developed mild fever prior to coming to the emergency department. He actually had a tragic history because as a 10-year-old, he was accidentally shot during a hunting expedition. Hunting is very, very popular in Minnesota. And at that time, they had to partially remove the lung, and he did actually well after that. And so the physician examined him, and he called me and I said, you have never seen this. He had a coughing spell, and he coughed up metal. So things progressed along. Patient really didn't get better, and this is how the x-ray looked 2 days later. And essentially the same diagnosis, but this time the radiology called me and said, you know, I'm seeing this linear air accumulation which is parallel to the cardiac contour. I'm not really sure what that is, but maybe you should look into that. And now we'll have the next slide. And this is the CT, which now should play if we click on it. And I'm only going to run through it once, because just to show you how distorted everything is here from the previous pneumectomy. Here is the ventricle. But for those of you who deal with this, you see all of a sudden all these little pockets of air showing up around the heart that really shouldn't be there, right there. You probably saw it. Let's play it one more time, then I can show it because the moving pictures are actually nicer. So when the heart shows up, watch right around here. There is actually air. There shouldn't be air around the heart. Okay, next slide. So here you can see it more in a still frame, more detailedly. This shouldn't be there. This is not part of the cardiac structure. Next. This should also not be there. This is a collection of remaining buckshot from the old bullet and from a lot of surgical clips. Next slide. And here you see that in the pericardium there is actually a connection. There is something that doesn't belong, because this is a bronchial structure, an endothelialized bronchus, and this is the pericardium, and there is a connection. So the next slide. So we said, well, let's just get an echocardiogram. And I'm going to make this very short. Here is the left ventricle. It works well. Here is the right ventricle. And here is the same pericardial space, but now there is something interesting in there. If this would be just fluid, you would see a black homogeneous space. What you are seeing is actually bubbles in there. And so let's go to the next slide. Sorry, it's frozen. Well, I'll continue to talk so that we stay a little bit on time. This patient had to go to surgery because what had happened is that with age, with him growing, with him pulling on these surgical sutures, he actually had created a connection between the layer around the heart and the lung. And he was once in a while pushing air into the pericardium. Furthermore, he had started to connect the old surgery with all the clips and the buckshot wound to his bronchus. And intermittently, he was literally coughing out bullets, tiny bullets. And so we went to surgery, and it was very involved. It took us 5 hours. We actually, this did not happen during surgery. If it would, we would go ballistic. But what we did, we literally had to reconstruct part of the lungs. We took a flap from the patient's own muscle, put it over the lung to actually cover the holes. We reconstructed the pericardium with animal tissue, and then we sewed everything up and cleaned out the clips. The patient did beautifully. He's actually following with me now for the last 3.5 years, and he's doing very, very well. So the moral of the story is a couple of things. When you are a cardiologist, life is just absolutely fun and interesting. 2, always make sure that you get a careful history and examination. And even in the last case where you say, this can't be true, you're not coughing bullets, when the patient tells you, maybe you should listen. Always make use of all the data. And one last thing, use every tool that you have and don't be afraid to ask. And thank you so much for listening, and I'll be very happy to answer any questions.
Thank you, Dr. Thomas. So it's very interesting talk of you, and I will facilitate you and the audience to have a nice discussion.
Dr. Thomas, my name is Rizky from Cardiology Department. Actually, I want to ask, maybe not in the imaging part, but this is more about the clinical, clinical part. In the first case, like we found aortic stenosis with multi-condition, multiple comorbidity. So, how about the decision to replace the aortic valve with the use of the anticoagulant after that? Regarding this patient have many things, many comorbid in the liver, in my point, because here we usually use the oral anticoagulant, and this drug will be affected by the liver condition. This is my question. And the
Mhm.
second is, so for in the case that this patient have multiple comorbidities, and how about to educate patient that uh, that she will be, even though the valve is already replaced, but in the future he will be, there is a complication that he will get the possibility of complication. Thank you.
First of all, I am absolutely amazed about your English, and I wish I would know Bahasa 10% as well as you do English. So congratulations. Your two questions are phenomenal. The first one I can answer very quickly because that's a content and expert question. In the past, the younger the patient was, we tended to use mechanical valves because they were more durable. They lasted longer. That's no longer the case. The lifespan of biological valves has gotten better and better and better. So the first year, it makes no difference. So in a case where you have a lot of other diseases, we prefer to have a bioprosthesis to have the additional complication of anticoagulation out of the picture. That's why I think our colleagues on the outside hospital chose a bioprosthesis, and I would have done the same thing. Your second question, even though equally good, is a philosophical one and difficult. At our clinic and our hospital, we unfortunately hardly ever see what we call naive disease. In other words, where the patient has only coronary artery disease, or only aortic stenosis, or only mitral valve regurgitation. We're getting the ones who have one leading disease and they have 10 others which made other institutions reject them. I like that because it makes you the best that you can be. It challenges you every day. It's hard because you sometimes ask yourself, look, I am doing all of this now, all this complicated, interconnected procedure to help you, but you are still eating whatever you want to, you are still hypertensive, you're still obese, you're still not exercising. It's true, sometimes it's frustrating. On the other hand, I'm a physician. It's what I do. So, yeah, our patients enter in America, usually for us at Mayo Clinic, as usually very sick. And I came from Germany originally, as I told you. I actually know that the first 2 patients wouldn't have been operated on in Germany. They would have been rejected because they were just too sick. I don't know really how to answer that. This is actually where my wife plays the biggest role because she helps me to teach the patients that they need to contribute their part to get better. Does that kind of answer the question, or did I miss it? The second part.
Thank you. But actually, we have also such kind of patient like that with comorbid in the cardiac, but also in another disease with another disease. So the problem is actually almost the same, that we have to choose which best to be, what best to be the patient, but also here maybe also the cost related to the procedure that we will do, like that. But yes.
Do you have, let me ask you a question.
Yes. Yes.
Do you have the integrated teams, like for example, for a patient like this, there would be automatically specialists from all groups immediately assigned to him. So there is, that they know that this is happening. So we would do in this case care conferences and planning procedures so that we would go, before we do the surgery, we would have all the specialists in the room and saying, look, tomorrow morning there will be a patient coming out of surgery who will have this valve, but they have got all these problems, so you need to be lined up to automatically do 1, 2, 3, 4, 5, and 6. So we do these planning procedures up front very carefully because they have shown to be extremely successful, so that people anticipate some of the problems that we have in these patients. One of the things that we are very proud of, our success rate with these patients is actually better than in other hospitals where the patient only has aortic stenosis. So we are very, very proud of that. But it does take a multidisciplined care team to get these patients through. Like, for example, I don't know how it is here, but when the surgeon is done with the surgery, he essentially has nothing to say about the patient anymore, except the part that pertains to a surgery. Care is now the responsibility of a critical care physician, a critical care cardiologist, and the appropriate specialist. I don't know how you handle that here. Is here still the cardiac surgeon then in charge? Okay.
We have a regular conference to discuss patient, especially surgery case, cardiac surgery patient.
No, I mean after surgery, who is the signing off? Is that still the cardiac surgeon then, or is that the critical care team?
We have also a team, not just cardiac surgeon, but also include cardiologists and anesthesiologists.
So it looks like you have a very similar system that we do.
Is that enough, Dr. Rizky? Thank you. And yes, we do have a multidisciplinary team for such cases.
Super.
Yes.
Yeah,
thank you.
it's otherwise we will never get them through.
Yes, otherwise just useless, isn't it?
Yeah.
So is there any other questions? I have a lot of questions for you, and we also prepare some cases for you this afternoon to discuss with.
Be happy to. How large is your cardiology department? How many cardiologists do you have at the university?
Maybe Dr. Haryadi.
We have 9 cardiologists here. Yeah, and the fellow, but the resident, 42 residents.
Cardiology residents.
Yeah.
Wonderful.
Yeah.
Fantastic.
We have many cases in ICU ward, and after lunch maybe discuss with them.
Echocardiography, treadmill, and so on is belong to imaging department. I mean, it is a part from cardiology department, or it is in one. Yeah.
Very good question. We have moved a lot in terms of reassigning where things belong to. So we are training radiology fellows to do echocardiography, and radiologists are training cardiologists to do MRI and CT. Stress echocardiography belongs to the stress center. There we do stress PET, stress nuclear, stress MRI, stress VO2 uptake testing, and regular stress testing. And so that is a center unto itself because there are so many disciplines running together. But we from the echo department contribute the imaging section there. In the OR, we share duties with our colleagues in anesthesiology, who we also train. And we just started a program with our emergency department to see if they can use, we bought 50 of those handheld devices, the GEV scans. They are a pocket device you can just put in your pocket. And we're teaching the emergency department and the kind of urgent care centers to use these and see if they are useful there to help them answer immediate questions like, how is the ventricle functioning? Is there any gross abnormalities like pericardial effusion that we need to consider? So it's really, it's from an administrative point of view, if you look at strictly where are the budgets, yes, we do have cardiology. But when you look at the application, it's often across departments. That's been one of the things that the top leadership absolutely enforces. You cannot create silos. That's not allowed. And I know I came from the German university. We were very good in building silos. Because what I have and you don't have, that's mine. It doesn't work for the patient that well. And you know, that just is not good.
Thank you, Dr. Really taught us a lot, especially the philosophies for working together, multidisciplinary, for the patient's sake, and also then don't hesitate to ask. That's the most important, I think, for us to take care of patients. So, any other questions from colleagues? So, any questions that you would like to ask about anything, about the patients, about the Mayo Clinic, about Dr. Beckenberg himself? Yes, so the incidence of tuberculosis is very high in this country, and we do have a lot of cases of PE due to that, the chronic PE due to tuberculosis. And what about your experience in Mayo? Do you have a lot of cases?
There is absolutely no doubt, and this is why we are always excited to look outside much. It's on the rise again. We're now beginning to see it, but for example, it's beginning to show up on our Indian reservations. But I came from, I still saw some tuberculosis. When I came to Mayo, they were gone, and we're now starting to see them again. So there are clearly things that we can learn. There are disease entities that we would love to learn, which we can definitely learn a lot from you.
Thank you. And sometimes we even saw this patient in very young age, like 12 or 15, and some in pregnancies. So it's really a dilemma for us. So, any other questions? So I will please you to ask in Bahasa Indonesia, and we will translate if you want.
Which one the modality you choose to differentiate thrombus or myxoma in the left ventricle? Because I have the case not established diagnosis. Which one modality you?
Hands down, MRI, cardiac MRI. I mean, remember, thrombus versus tumor have very distinct tissue characteristics. For tissue characterization, hands down, MRI. You can help yourself by saying, okay, I can look at the blushing of the tissue by doing, instead of a CT functional, you stay on the slice that you have and you follow it temporarily, so you change your imaging protocol. We do that too. in patients who we feel need a faster examination, because MR, even though we have gotten very good, is still taking a little longer than CT. But if you say, I really want to do tissue characterization, like for example, subendocardial infarction, the patchy scar of myocarditis, chronic myocarditis, MR is the best.
Yeah, for addition, so for that case as well, we will show you the echo and just a brief case illustration this afternoon, and some other cases. So this afternoon, all of the fellow resident will be there, and we would like to have you for discussion. And we hope that you can teach us we hope that you could teach us the way you read the imaging, the cardiac CT, and also just the thorax CT, and etc.
How many years do I have for that? How many years do I have to teach?
Just briefly. One last opportunity. Do you have any question for Dr. Frankenberg? Yes, Dr. Wina, please.
Yeah, from cardiology department. I'm so surprised to see a very large Mayo Clinic and a very lot of cases that you you have in your hospital, and maybe it's a challenge for you to you have done a lot of cases with a lot concomitant disease. So this is very new for us here, because we're not that long. Our cardiology department and cardiac surgery is not that very long. So we have multidisciplinary. We have sometimes converse with cardiac anesthetic, but not all the cases succeeded, because we just not that because we are not that long. We're new for the cardiology, and what I'm asking is about post-procedural, because we are doing pericardiocentesis sometimes in emergency. We are doing with just an echocardiography.
Mm-hmm.
Yeah, pericardiocentesis with echocardiography. But sometimes we did it in laboratory catheterizations with the sometimes we're done in with cath lab. In cath lab, we're done in with cath lab. But usually in emergency, we done pericardiocentesis in with just in echocardiography guiding. So what I would like to ask you, you said that we need to keep on, observe the patients after the procedure. So what I would like to ask is, what do we need to observe with the, because we don't have that lot of imaging. We just have echocardiography and MRI. So we usually just put the patients in observe like a hemodynamically vital sign and echocardiography, just that. Maybe you can have suggestions for us for pericardiocentesis.
Actually, if I got to look in my computer, 5 years, of course, how old I am. He is one of the most brilliant people you'll ever meet, and he and I are doing a lot of the interventional invasive cardiology together. And we just finished. We have a protocol, very simple, stepwise protocol to do after a pericardiocentesis. Let me ask you a question. After pericardiocentesis, do you leave the pigtail catheter in the pericardial space?
Yeah, it depends on the case. Usually, yes, because if the patients have a tamponade, and we usually leave the pigtail.
Excellent, because you should. Because otherwise you will have about a 20 to 25% chance that you have to go back in. Because as you know, the drainage, we have shown this, we have published this, the drainage drops down within the first 36 hours. So you should never really pull a pigtail 24 hours ahead. And there are very simple guidelines that you have to. You got to teach your nurses that they withdraw every 3 to 6 hours to see how much fluid they can get out. And if the volume drops under 50 cc's per 24 hours, then it's time to pull out the catheter. And we have a very simple protocol on you don't get a chest x-ray directly after the procedure. You get one chest x-ray about 24 to 36 hours later to see if you got a pneumothrax. And then we have a list of things you can do for pain control because, you know, once you got successful drainage, people don't like it. So yeah, no, it's very simple, and we are to the point now where our nurses feel empowered to then, with this protocol, to pull the catheter. We don't even do that anymore. But you are right. It goes to show you how much younger you are, because I started out doing pericardiocentesis with a needle-guided electrocardiogram, and when we would hit the ventricle, we knew we'd gotten too far, because then we would see the ST segment elevation. Then we did it with a cath lab. Then in Germany, I did it blind from the lower portion, just with a, you know, after you're taking the chest x-ray. Bad days, really bad days. Now we only do it with echocardiography, because the rule number one, when you see the fluid, that's where you go through. That's where your excess is. So pericardiocentesis has become very simple. And if you really follow, it's a cookbook, it's a recipe like, you know, making coconut cookies. You follow it, you have a very, very high success rate. There's no magic. It's just you discipline, and people cannot just say, oh, you know, I'll just think I'll pull it. That doesn't work. Thank you for
Thank you. Thank you, Dr. Reed.
Good morning. There we go. That's better. Good morning, and thank you very much, the leadership of university, also Echo Hospital leadership, and all the students here today. I'm pleased to be here and have the chance to be in beautiful colonial Jakarta. We've enjoyed driving through the city and experiencing some of your delicious food and all the sights and wonderful experiences that we have. And there I started as a nurse at the bedside in orthopedic surgery. And within about a year or so, I decided I wanted to further my education, so I went back to the university, and I was very interested in hospital administration. But at that time, this was in the early 80s, I was also interested and realized that I was very interested in data, and I realized that computerization was coming to the hospital setting. So I studied nursing administration and also health computer science. And when I started at the Mayo Clinic, I actually was hired as a informatics specialist. So I was very involved with the introduction of the electronic health record at Mayo Clinic. We currently have a integrated, comprehensive electronic health record that we started implementing in the early 2000s. And I did that for a number of years and helped implement the electronic health record I was helped to be the liaison between the clinical world and the technical world, because as you know, they speak really two different languages. Shortly, I did that for a number of years, and then I was in the Department of Nursing, and I realized that we needed to better understand data now that we were more electronic in the Department of Nursing, because very often when we were coming forward with a proposal, wanted to change our staffing, things like that, we had no data to show and to make our case and to make our argument to administration. So at that time we developed a position of administrator for information and quality. And so I went into that position as administrator for quality and information in the Department of Nursing. And I did that for a number of years. And now, more recently, one of the interesting things about Mayo Clinic is that you can, my husband explained to you sort of the broad nature and the expanse of the Mayo Clinic. So you can have a number of different careers if you choose, depending on your background. So in more recent years, I decided I liked working in the more consultative analytic role. So I moved, we have a department of patient education. And I realized that patient engagement is a very important part of the healthcare and wellness of the population. So I moved to that department, and now I work, we have like a small publishing warehouse where we produce patient education materials that have a certain level of credibility that we like to give our patients. But I actually work with the care providers and consult with them about how to provide excellent patient education. And I also work, we have, as you do, for example, the Joint Commission, the Medicare, Medicaid of the governmental insurance that regulate healthcare is a heavily regulated field. So I work with them to help translate the patient education standards in the organization. And then, of course, I still work with the electronic health record from a patient education standpoint. So with that introduction, I'll go into the first slide. In the early 90s, now this was, you might remember in the 80s in the United States, there was a push with healthcare financing model to move to the diagnostic related groupings, the DRGs. Then in the 90s, we had another healthcare crisis, and we were moving to managed care. And in managed care, one of the things that happened because of the crisis in financing is hospital leadership was coming in and saying, we are going to reorganize the Department of Nursing or other departments, and we're going to bring in less skilled people, potentially, to provide patient care. And this is where I mentioned earlier, we were in a little bit of a dilemma because we didn't have the data to show that an educated professional nurse might have an impact, a better impact on patient care and patient outcomes than a less skilled person. So at that time, through the American Nurses Association, of course we had talked about this many times and knew about this dilemma. But until we were pushed to do it, we didn't really see this happening. And that's one of my take-home messages, that you as leaders, it's important to push for these things. Don't be afraid to push for these things, because otherwise they may not happen. But at that time, the American Nurses Association pushed forward vigorously with what they call nurse-sensitive outcomes so that we would have better data. And the conceptual model for this movement was based on the Donabedian structure, process, outcome model. So the as I mentioned, the nursing sensitive quality outcome measures are, the program is supported by the American Nurses Association, but the work is actually carried out at the University of Kansas in Missouri. Okay, next slide, please. So there are 18 indicators that have been developed over the last 20, 25 years now. And so they are broken down into, as I mentioned, more the structure, process, and outcome. So, for example, now we have measures that very specifically and in a standardized fashion, this is very important, collect data on, for example, nursing hours per patient day, nursing skill mix, in other words, what are the qualifications of the nurses providing care, nurse turnover rate. As you know, it's very expensive to hire new nurses. In the United States, we figure it's $22,000 to $66,000 to hire a new nurse. RN education and certification. Education has become very specialized as the science of healthcare increases. There's also an RN survey that this program enables you to carry out with your staff once a year. And the RN survey evaluates the practice environment scale and the job satisfaction scale, so that you have a sense of how satisfied and how, in terms of the professional environment, how comfortable your nurses are. Assault and injury rates, and then we get into some of the hospital-acquired outcomes, undesirable outcomes, such as catheter-associated urinary tract infection, central line-associated blood infection, falls and fall injury, hospital-acquired pressure ulcer rates. We know with these things, in fact, the Medicare, Medicaid is coming forward now and actually implementing that the hospital will not be reimbursed for these hospital-acquired situations. And as you know, if a patient develops any of these infections or ulcers, the expense of the patient staying in the hospital adds up very quickly. We have the pain assessment and intervention reassessment cycles. I know on the last Joint Commission survey we were dinged on this. So this is it's a difficult intervention to implement, but it's a very important one, obviously, in terms of the comfort of the patient. Peripheral IV infiltration rates, physical restraint. We know that as the patients are restrained, very often undesirable injuries occur. And then ventilator-associated pneumonia rates. So for the first time, for institutions implementing these, Mayo Clinic, I was instrumental in implementing these at the Mayo Clinic. And for the first time, this was back in the 90s, we had comparative information that we could benchmark amongst ourselves, but also across the country with like facilities. And so on a national level, when it came to policy development, we could also, as a profession in nursing, talk about the relationship between nurse staffing and patient outcomes with data. Next slide. So some of the benefits are improved nursing quality. Obviously, if you have this information, you can start looking at your quality improvement program and actually using this data to set your priorities and see where you need to improve. Nurse retention. As you may be familiar in the United States, and I'm starting to learn a little bit about the profession of nursing here in Indonesia. The nursing shortage kind of goes like this, and you kind of adjust to where you are on that stream of nursing shortage. But being able to improve your nurse retention with making changes in your work environment is a very good thing to do from a professional development standpoint. It's also very important from a cost standpoint. As I mentioned, the governmental Medicare, Medicare insurance companies are now requiring that we report data. And so this allows us to meet those requirements. I talked a little bit about the benchmarking. This is so helpful to compare across institutions, compare yourself to other institutions. The other thing is the networking. All of a sudden, if you become a member of this database, you can work with other institutions and say, oh, what are you doing for pressure ulcer protocols? What has worked? What doesn't work? You have actual data to compare. And then also research. Nursing in the United States has a very rigorous research program, nationally funded, independently funded, that has developed over the years. And so we are able to develop the profession through research. Obviously, through this program, you have access now to reports. The data is reported quarterly, so you can see the data in tabular dashboards. You can put together custom graphs. So this is very helpful for operational in your department, but also as you're proposing new programs to come forward with actual data and compare, as we talked about. The other thing that this program allows you to do is actually compare your data with hospitals like size. If you're a university hospital, you can just select university hospitals to compare with. You can, if you're focusing on cardiovascular care, you can just pull out cardiovascular programs to compare with. So there's a lot of slicing and dicing and individualizing that you can do. And finally, in implementing the program, it's really very simple. You join the program, and I understand that, well, currently there's, I believe, over 1,500 hospitals in the United States that are members of this program. And I believe that there are some, I know internationally you can join as well. I don't know how many international participants they have, but it is open internationally. And really all you need to have is to join, the cost of joining ranges from about $1,800 to $10,000 a year based on the size of your organization. And then you also need a person that they call the survey coordinator for the data collection. And that is the point person back to the national program. And this person can go through some online training on the definitions of how to collect the standardized data. You may have to do some adjustments in your organization as far as how you define the data and how you collect the data, because you obviously, to be able to standardize and compare the data, has to have a common definition. That's probably the most time-intensive piece, is to get your data systems and collections set up appropriately. And then there are many other benefits in terms of newsletters and teleconferences and other networking that can occur and evolve and develop with the program. So that's the content that I had on the nurse-sensitive data program. Before I move into the patient education, are there any questions? I'd be happy to try to answer. Okay, very good. I'll proceed with the patient education, and maybe we can save all the questions to the end. Next slide, please. So in this presentation, I'd like to talk a little bit about how we define quality patient education at Mayo Clinic. I'd like to talk about health literacy, what it is, and the movement and how we can advance health literacy. I'll talk about some of the trends and resources that we have at Mayo Clinic in terms of patient education and the impact of patient education in healthcare generally. So we define quality patient education as following the usual decision-making care coordination process that is used in really any type of care process, beginning with the assessment, the learning needs assessment, understanding where your patient is, their capabilities, moving on to the plan, so developing an individualized plan. Again, going back to the patient comes first. Even though you may have standardized protocols and processes for the key points of what the patient needs to learn, it's very important when we try to individualize it to that patient's needs, and I'll talk a little bit more about how to do that. Then implement it and evaluate the learning. If the patient didn't understand what it is that you need them to know to take care of themselves at home, then you as clinicians were not successful. The learning needs assessment is actually a very key component of patient education. First of all, it's important to find out what the patient or family already knows about the topic. And you can do this with a few very specific open-ended questions, and I'll share a few of these with you later on. And also understand, make sure you uncover that it very likely have some key concerns that are specific to their situation. Make sure you uncover those and understand those so that you can address them. Then there are also many factors that may affect the patient or family's ability to learn. In the United States, we have a very rich, diverse population with many minorities. And there may be a minority, for example, we have many refugees that moved to Rochester from Somalia, and they actually make up a fair portion of our population right now. And it was very important that every employee at Mayo Clinic understood how the Somalians make their medical decisions. In their family, who makes the medical decisions? Because that was very different than our culture. And so understanding your minorities and how medical care is and health decisions are made in their families is very important. And your employees should all have education and understand that. And then there just are factors like maybe financial concerns, emotional state. When a patient has just found out a diagnosis that's going to have a huge impact on their life, their emotional state is obviously going to affect their readiness to learn. Religious, cultural practices, all these things are very important. And also the learning style. We know through cognitive development that some people learn by dialogue, talking to one another. Some people need to see the visual. Some people like to read. And so it can be helpful just to ask the person, how do you like to learn best? And try to accommodate that the best you can. And of course, you have people that are hard of hearing, do not have good eyesight, may not be literate. These things need to be understood and known. So as a review, in providing quality patient education, we go through the assessment plan implementation evaluation process. We provide patient education by qualified healthcare providers. So for example, by your license, for example, nurses, one of their items that they're licensed to do is to provide patient education. Whereas we have a level of nurse called the licensed practical nurse. It would be outside of their scope. They can reinforce education, but it is outside of their scope of practice to assess or evaluate education. So it's important to know what your professional's scope is and what their education and competency is to provide patient education. We ask